Hello, everyone. Thanks for joining me. Sorry I couldn't be there in person today. I wanted to talk about bedside evaluation, which goes hand in hand with bedside teaching as well. You can't evaluate someone on their bedside manner and prowess unless you also watch them or teach them at the bedside. Sir William Osler said, to study the fauna of disease without books is to sail into uncharted seas, whilst to study books without patients is to not go to sea at all. Without learning on our patients and practice-based learning, we will fail to get the entire scope of what we need to teach these residents. So bedside teaching used to be very popular. Back in the 60s, it was 75% of teaching, whereas today it's only 8 to 18%, depending on what studies you look at. It's been shown that the bedside teaching and evaluation can increase clinical and diagnostic skills, also increases satisfaction of the learners. But why is it decreasing? There's a lot of reasons that are put out there, but I think a lot of it is just kind of a change in culture and the way that the hospitals are running. There's more turnover, there's increased reliance on technology, and we just fail to do this like we used to. When we evaluate the residents, a good evaluation requires observation. And who's observing them? Everybody is. It's not just us, but the nurses, the techs, patients, guardians, family members. Everybody's going to be evaluating our residents. And through different mechanisms, we'll try to get those reviews and that feedback back to them as well. But we can definitely take note. We can actually ask these people. They can augment our observations as well as what we directly observe. When we do evaluations, we want them to be subjective. This is very difficult. Everybody has their own thoughts about things, and people do things differently. So trying to keep things subjective and consistent can be difficult at times. There's different preferences for techniques, styles. There's certain biases that are implicit. Professional differences. Some doctors tend to work up things more than others. They work them up differently. Somebody might think you're doing something incorrectly when another person might say that's the right thing to do. Halo versus horns is one area of subjectivity that can actually be very detrimental to a resident. People tend to get ideas about certain people. It's just a given. And then there's people turn into good residents and they turn into bad residents. And that can color our evaluation and our interpretation of what they're doing. Another lack of subjectivity is laziness on our part as the evaluators. If we don't take the time to actually sit down and do a thorough evaluation, then we may be giving the same evaluation to people who are doing things very differently, and that's not fair to them. It doesn't help them. The ACGME wants us to evaluate in these key areas. Patient care. That's how we're taking care of the patient. It's pretty straightforward. Procedural skills are probably one of the most straightforward because it's an actual thing you can evaluate. Technique as far as how well they did it and the outcome. Medical knowledge is something that we will evaluate as they're seeing patients, and we will evaluate at the bedside as well. But that is also something that's evaluated through tests and other things throughout the residency. Practice-based learning and improvement is what we really want to focus on. So practice-based learning is them learning the craft of emergency medicine by working in the ER. This is what they're here to do, and we need to make sure that they're taking the opportunities with the patients that they're seeing, the problems that are presented to them, and they're turning that into teachable, learnable things. Interpersonal communication obviously is very important between us and them, as well as them and the staff, professionalism, and then system-based practice. We also need to evaluate their ability to navigate the system. Can they do what they need to do for their patients to get them through the system appropriately, quickly, and efficiently, and can they function there? So why are we reviewing them? We want to review them to monitor progress, to identify areas of growth, set goals, guide development, provide feedback, define and document problems for future use if necessary for any kind of remediation. This is all fairly basic. We know these things, but we just have to make sure that when we're reviewing and we're evaluating that we keep these things in mind. In evaluations, there's a lot of missed opportunities. Criticism is great, but criticism without correction is not very helpful. Lack of effort on our evaluations is another thing that can be a missed opportunity. Something happens and we don't take the time to point it out and correct it, that is a lost opportunity. Not defining goals. This goes with the corrections part. If we identify something, we have to help them identify what their goal is, what their target is, in order to improve upon that deficiency. And then also proactive remediation. This can take a lot of forms, but one of the more common and useful ones is you'll see as residents progress, sometimes people start to cut corners or something that they used to do really well, they may not be spending the time on that they used to, such as following up with a patient or taking the time to develop a rapport. And if you see something like that slipping, being proactive and trying to intervene before it becomes a problem is a very important thing. And when it's not done, that is a lost opportunity. So our evaluations should be structured. If we structure our evaluations, it improves accuracy, improves consistency, tries to take out all those different biases and lack of subjectivity so that there's some inter-operator consistency, and that will help the residents as well. We need to review, debrief, and teach using these structured data, both at the bedside in real time, but also we can take these evaluations and put them together and look for patterns and other things that we can teach and help them with. So the effective reviews will be transparent, objective, fair, and predictable. I don't like anonymous reviews, but obviously at the bedside, that's not going to happen. When we teach them at the bedside, we're telling them what we saw, what they can do. We have to be objective and fair with our criticisms. Not everybody is the same, and not everybody is at the same level. We also need to be predictable. When they know what to expect, a lot of times they'll actually be able to do a self-review and a self-criticism as well as we can. Sometimes they'll be much harsher on themselves. So what's our job in all of this? So we need to set expectations. We have to realize that everyone is different and understand how our residents are different and how to approach them. This will take a little bit of time, obviously, but you can't approach everybody the same way. So, you know, you can tell some people that they really sucked at that and they'll be fine with it. They'll take that, they'll learn, whereas somebody else, you know, using such terminology might, you know, pull away, take it offensively. We need to be able to communicate and clarify. We need to understand that making a small comment here or there, especially at the bedside, because it's not written down necessarily in black and white, we need to communicate exactly what we would like to see different and make sure that they understand that. And also, again, going back to the measurable goals and objectives, give them something that they can shoot for. It's also incumbent upon us to be open and willing to learn and adapt to our styles based on what the residents need at the time. We also have to be open to being evaluated ourselves. We can always do better, and we can always improve, and we can help each other in this by watching each other and giving each other some feedback once in a while. 3-2-1 is something that I was thinking about. When it comes to this bedside teaching, you know, there's going to be after shift evaluations, and those are pretty standard, and we'll talk about that in a second, or give you an idea of an idea for that in a second. But the 3-2-1 is an idea for how we're going to actually observe them. In the busy emergency department, we can't follow them around and watch them at every patient. We don't want to. We actually want to give them some freedom to actually go out and learn a little bit on their own, but we have to watch them as well. And they're going to be here for 3 years, and it might be a good idea for us to try to observe, you know, 3 interactions during their intern year, 2 interactions during their second year, and at least one interaction during their third year. I mean, a lot of third-year residents think they've got it nailed and don't need to be directly supervised, but I think that we'd still benefit from direct supervision and occasionally having someone watch us and give us some critiques. And I think it's going to be important for us to continue with them throughout their the residency with us, and having a rough framework of something like a 3-2-1 model, where we just try to make a point of going in that many times with them during the shifts would be helpful. It helps structure things, and it also helps them with the predictability aspect, because they know what's going to happen, and they don't think that just because somebody's standing over their shoulder they're doing anything particularly wrong. So this is a example of end of the shift evaluation. All of the bedside evaluations can come into this. The initial part of the bedside evaluation is just a conversation afterwards while you're walking back to the fishbowl, but that can be reinforced, and this is where you can really lay out those goals, but we have to take time to fill it out. This is the rough outline is from Michigan State, but I did change a few things in this, and I'll send it all to you guys so you can take a look at it and see how you want to change it and reword it. I'm sure that there's some improvement here, but the main thing here is that we're not giving them all 9s and 8s at the beginning here. We're going to make sure that they know that there's always room for improvement, and that's kind of highlighted by either at expected level. So, you know, most residents, most shifts, we're going to be getting 5s and 6s, and that's okay, and that's good. If they do something stellar, then we can definitely point that out. But when we do the bedside teaching, we want to take all that stuff through that shift, and then we would come back to a written document like this, where we can actually put it all down in black and white, reinforce the things that we had spoken about, and then they can use that in order to improve their practice. And it's a 2-page thing. It's a little bit dense, but I think as we start to use it, it'll go pretty quickly. And one thing that was very important that Dr. Boss pointed out is not only setting clear goals and objectives, but also fine points. Like, you know, if we can take one thing per shift to point out as an area for improvement or for them to work on, that will be much more helpful than downloading a bunch of stuff right at the end and saying there's 10 things to do. Identifying 1, 2, maybe 3 things that are the most significant that you saw will be very helpful to them. So sorry I'm not there to take any questions, but if you have any, please let me know, and I will see you guys all soon.